The following podcast is part of a certified educational activity titled Upfront Upgrades for Mantle Cell Lymphoma, integrating the first-line use of BTKi strategies across patient populations. Access the entire activity and complete the post-test at peerview.com/TZE860. Downloadable slides and practice aids are also available.
Good morning. Welcome to the symposium with the title of Upfront Upgrades for Mantle Cell Lymphoma, with the subtitle of Integrating New Strategy Across Patient Population and Implication for Sequential Care. I think this is a fantastic time for mantle cell lymphoma patients and doctors involved in mantle cell treatment. As you know, there is an unbelievable Sudoku situation inside the mantle cell therapeutic algorithm. And so the panelists today are myself, Pierluigi Zinzani from University of Bologna, Italy, Christian Rian from Dana-Farber Cancer Center in Boston, United States, and Professor Carlo Visco from Verona, Italy. Our goals for today are improve your understanding of guidelines and evidence supporting newer frontline treatment options for mantle cell lymphoma, help you to develop more personalized treatment. This is a very important point, to personalize the treatment plans for patients with new diagnosis mantle cell lymphoma. And finally, enhance your skills for managing dosing and safety consideration when integrating target agent into the upfront management of mantle cell lymphoma. Okay, we come back to the normal slide. I mean, conventional chemotherapy remain a mainstay of frontline care for mantle cell lymphoma in the United States, and is now joined by BTK inhibitor-based regimen. As you know, according to the presentation at ASH meeting by Martin Reins in 2022, in 2024 with an update, and also the publication of the triangle. Also in the United States it's possible to use this kind of frontline treatment for untreated mantle cell lymphoma with an age until 65. But of course, according to the NCCN guideline, it's possible in the United States to choose among ibrutinib or acalabrutinib or zanubrutinib in terms of BTK covalent inhibitors. And on the other hand, I think it's important to remember the concept of maintenance treatment after autostem cell transplantation or aggressive induction therapy using a covalent BTK inhibitor for 2 years plus rituximab every 8 weeks for 3 years. But I think the maintenance treatment after less aggressive induction therapy could be another important point concerning the role of rituximab every 8 weeks for at least 2-3 years following R-CHOP or BR. And also the concept of maintenance treatment with rituximab following EverCap or RBAC 500 has not been evaluated so far. And finally, in January 2025, I mean no more than 4 months ago, acalabrutinib was FDA approved in combination with bendamustine plus rituximab for the treatment of adult patients with previously untreated mantle cell lymphomas that are ineligible for autostem cell transplantation. And at the same time, it could be very important inside the frontline treatment in terms of a recommendation for mantle cell lymphoma, the patient fit for autostem cell, a patient unfit for autostem cell transplantation. And as I said before, you can consider the role of the inclusion of ibrutinib in the frontline treatment using 2 different chemoimmunotherapy treatment, and then avoiding the role of autostem cell transplantation with also 2 years of maintenance treatment with ibrutinib, and at the same time also rituximab. We see some data concerning the real role also of rituximab and this kind of concept of maintenance treatment. For the unfit patient for outer stem cell transplant, for sure the most important last step is the official indication of ECO study for patients ineligible for outer stem cell transplantation with an age more than 65, using the combination of conventional chemotherapy, in these cases, bendamustine plus rituximab plus acalabrutinib, and then there is a maintenance treatment using rituximab and also acalabrutinib. Just to remember, in terms of regulation status in Europe and United States, according to the EMA and FDA respectively, the official indication of the covalent BTK inhibitor and of the non-covalent BTK inhibitor. We start with the first generation covalent BTK inhibitor, ibrutinib. There is an official indication in Europe. There was in the United States until 2 years ago, that was deleted. Acalabrutinib, the second generation BTK inhibitor covalent, was approved in Europe, including also for the front line, and right now with the official indication of the ECO study, and also is approved at the same time in the United States. The last second generation BTK covalent inhibitor, zanubrutinib, is approved after the frontline treatment in the United States. There is a phase 3 study. We are waiting for the phase 3 study for the approval in Europe concerning that. Among the non-covalent, as you know, there are two non-covalent BTK inhibitors, pirtobrutinib. There is an official indication in Europe for relapse with this kind of definition, relapse refractory mantle cell lymphoma after BTK inhibitor covalent therapy. And it's a little bit different, the indication by FDA, because after 2 or more than 2 lines of systemic therapy, including a BTK inhibitor, because this could be is a kind of different situation when they move in second line according to the potential new indication of triangle in front line. The other non-covalent BTK inhibitor is nemtabrutinib, is on phase 2 study. And another important point inside the treatment of mantle cell lymphoma is this publication 4 years ago. Bond and co-workers presented this data concerning the progression of mantle cell lymphoma within 2 years, 24 months, from the start of treatment is associated with an inferior overall survival too. And you can see this kind of curves in terms of overall survival. This was the training cohort, and then there was also a subsequent validation cohort inside the publication. And the data really important and interesting. There is a really important stratification when you compare the POD24 and the POD more than 24, the POD between 6 and 24 months, and the patients where the progression during the induction or within the first 6 months from the end of the induction. So this is a fantastic evaluation concerning the real difference among these 3 subset of patients. And another important point, everybody knows the role, the negative role of p53 mutated inside the patient with mantle cell lymphoma is a very important area that, unfortunately, so far is an unmet need. And you can see this data published several years ago by Eskelund and co-workers concerning the big difference, really statistically significant difference in terms of overall survival when you compare no p53 mutation patient versus mutated patient. Of course, the P is statistically significant. And is there a potential to improve upon standard of care conventional chemoimmunotherapy? This is a very big question mark for the future for us and, of course, for our patients. Thank you very much for this introduction. And then we move to the first presentation. I am the same And again, I am Pierluigi Zinzani, professor of hematology working in the Institute of Hematology of the University of Bologna, very close to Milan. And the title of my presentation is Upgrading Combination Newly Diagnosis of Mantle Cell Lymphoma, Guidance on Applying Evidence in the Transplant Setting. And this is the patient, Simone, 58 years old man with stage 4 mantle cell lymphoma, present with weight loss, fatigue. Additional findings is Ki67 30%, no p53 mutation, performance status of 1. So I mean, in this panel discussion, we have 3 important questions. Is conventional chemotherapy followed by autostem cell still the standard of care? Can a BTK inhibitor containing combination be considered here based on current evidence and guideline? Does triangle support this choice? And we start with, does ECOG-ACRIN suggest we can eliminate transplant in this case? What patient factors can inform plans for frontline therapy, including when electing to forego autostem cell transplant? And you know very well this presentation by Dr. Fenska at the last ASH meeting concerning the final analysis of the ECOG-ACRIN is a fantastic trial supported from several American centers with the title of Lack of Benefit Autostem Cell Transplantation in Mantle Cell Lymphoma in Frontline in First Complete Metabolic Response with Undetectable Minimal Residual Disease. You can see here the study schema. And I think it's important the inclusion criteria, patient with an age ranging between 18 and 17, candidate for autostem cell transplantation with any rituximab-containing induction regimen allowed, including also BTK inhibitor. They included 650 patients, and the MRD evaluation assessment was done according to the clonosec. And at the end of the day, post-induction, there was a restaging, including also, of course, the MRD assessment. And in this case, for patients in complete metabolic response, MRD negative, there was a randomization between arm A, autostem cell plus rituximab for 3 years, versus arm B, only rituximab maintains treatment for 3 years. For patients who had a complete metabolic response but MRD positive, or MRD positive or negative in patient considered in partial response, was the arm C, autostem cell transplant plus rituximab for 3 years. You can see here the study population of this child with the 4 different arms, with a total number of 650, but we have to fix our attention on the arm A, arm B, considering the different maintains treatment with autostem cell plus rituximab versus only rituximab. There are no statistically significant difference when you compare the 2 subset of patients. They are very well balanced, and at the same time, overall survival. This is one of the primary endpoint. There are no statistically significant difference when you compare arm A versus arm B. So there is no real role of autostem cell transplant in terms of overall survival in this patient who obtain a complete metabolic response and with MRD negativity. And the same situation in terms of progression-free survival. The 2 curves are absolutely overlapped. And there is no statistically significant difference. And this, I think, is a very important concept in patients with MRD negativity and complete metabolic response. You don't need consolidation with autostem cell transplant. You can have only the toxicity without any kind of benefit in terms of overall survival and also in terms of progression-free survival. The second point on the basis of this case is what is the impact of the new triangle study on this patient frontline treatment. You know very well the data presented by Martin Dreiling at the ASH meeting 2022 and published the last year on Lancet. I was involved, my center was involved in the triangle trial. And you can see here, after 31 months median follow-up, the combination auto plus ibrutinib was superior to the conventional arm, including only auto transplant. And the 3-year failure-free survival was 88% versus 72%. Of course, the P was statistically significant. The other risk was 0.52. At the same time, the group A, auto stem cell transplant, was not superior to the group including ibrutinib without auto stem cell transplant. And again, you can see a real difference in terms of 3-year failure-free survival, 72% versus 86%. In the auto stem cell transplant arm, 83% of patients received rituximab maintenance after auto stem cell transplant. This is another important point concerning the real role also now, at the time of triangle study, concerning the role in terms of maintenance treatment, also for rituximab, not only for the BTK covalent inhibitor. This is the update presented at the last ASH meeting a few months ago in San Diego by Martin Dreiling with 55 months of follow-up. And you can see here that the failure-free survival comparing the curve, including auto plus ibrutinib, is absolutely superior when you compare with the curve of patients who received only auto stem cell transplant consolidation. And the situation, when you compare the two study arms, I mean ibrutinib without auto stem cell transplant or auto stem cell transplant plus ibrutinib, there are no statistically significant difference. 82% versus 81% in terms of 4-year failure-free survival. In terms of toxicity, there are no difference in terms of toxicity when adding ibrutinib to induction versus conventional chemoimmunotherapy. At the same time, there is an increase in toxicity with ibrutinib post-auto stem cell transplant. This is another important point to remember. And during the presentation at the last ASH meeting, Martin Dreiling fixed the attention of the audience also concerning the evaluation in terms of failure-free survival inside the triangle study when you try to compare the patients with a Ki-67 percentage, at least 50 or more than 50%. And you can see here there are a difference in terms of failure-free survival because the best is the arm including ibrutinib plus auto stem cell transplant versus the study arm including only ibrutinib. There are no difference at the same time between these curves that are absolutely overlapping when you stratify the patient according to the Ki-67 percentage less than 55. I think it could be very important to remember this point because if you use triangle in frontline treatment, you have to remember that potentially in high-risk patients, in some patients, could be important to use both ibrutinib plus the old auto stem cell transplantation. But I think this is a decision they have to take patient by patient. In terms of overall survival, the last update, 4 years overall survival for the auto stem cell transplant arm, 81%, was 90% for the study arm, including auto plus ibrutinib. And this is another important point. There are no difference in terms of overall survival. There is absolutely an overlapping of the two curves when you compare the two study arms, I mean ibrutinib versus auto plus ibrutinib. Ladetto, Marco Ladetto, presented at the last ASH meeting the data, the real role of rituximab maintenance treatment inside the triangle study, and I think it's important to combine the two maintenance treatment, ibrutinib and rituximab, because there is a real difference when you compare patients who didn't use the maintenance treatment with rituximab versus patients who went to rituximab maintenance treatment in terms of progression-free survival. These scores are quite clear about that. The last point is there a case to be made for substituting ibrutinib with the second-generation BTK inhibitor, covalent BTK inhibitor, based on triangle and head-to-head data? Do you remember in the NCCN guideline I discussed before with Professor Ryan, they started in the United States at least 3 years ago. It was possible to use ibrutinib or acala or zanubrutinib. And you have to remember, we come back to the safety summing up from the pivotal BTK inhibitor trials in the setting of relapsed refractory mantle cell lymphoma, comparing ibrutinib, first generation, versus the two second generation, acala and zanubrutinib. In terms of median prior line of treatment was 3 for ibrutinib, 2 for both acala and zanubrutinib. The median age was quite the same, 68, 68, and 61 for zanubrutinib. In terms of discontinuation related to adverse event was the same, 7%, 6%, 9%, no real statistically significant difference. In terms of grade 3 or more than 3 adverse event, neutropenia was 16% for ibrutinib, 10% for acala, close to 20% for zanubrutinib. In terms of major hemorrhage, was close to 5% for ibrutinib, less than 1% for acala, and 3.5% for zanubrutinib. Atrial fibrillation, close to 5% for ibrutinib, 0 for both acala and zanubrutinib. Hypertension was not reported in ibrutinib, was not reported in acalabrutinib, 6% in zanubrutinib patients. And I think the head-to-head trials confirm, because remember there are several, at least 2, 3 head-to-head trials comparing the different BTK covalent inhibitor, confirm the hypothesis that more selective second-generation BTK covalent inhibitor, acala and zanu, have fewer off-target effects, which contribute to less toxicity versus the ibrutinib, the first generation BTK inhibitor. And I think this supports substitution in triangle-based treatment regimen. We can see in the future, and the first data will come from the United States concerning the evaluation if there are some difference when you include the second generation BTK inhibitor inside triangle comparing with the inclusion of the first generation ibrutinib. And 2 examples from the Elevator trial, the lower incidence of key adverse event with acalabrutinib versus ibrutinib in terms of atrial fibrillation, in terms of hypertension, in terms of bleeding. And the same situation in another head-to-head evaluation inside the Alpine study. There was an improved progression-free survival, lower rates of atrial fibrillation when you compare zanubrutinib versus ibrutinib. In conclusion, in the ECOG-ACRIN study, initial analysis of this huge trial, more than 600 patients, shows that in the era of a highly effective induction and maintenance regimen, mantle cell lymphoma in first complete metabolic response with MRD negativity did not benefit from consolidation with autostem cell transplant. This, I think, is a very important point. Patients who remain MRD positive after the induction may benefit from autostem cell transplantation in terms of progression-free survival and also in terms of overall survival. MRD positive patients who converted to undimensioned MRD 6 months post autostem cell transplant appear to have improved overall survival and also progression-free survival. In younger patients with an age less than 65, the triangle plus ibrutinib, the conventional triangle, improves progression-free survival and overall survival. Could be interesting, potentially important to use to add auto stem cell transplant in high-risk patients. This is a question mark. As I said before, you have to evaluate patient by patient when you have a patient with p53 positive or mutated, and also with a Ki67 with more than 50%. The potential role of second-generation BTK inhibitor, I mean Acala and Zanu, in the setting of triangle study could be very important, but we need more data to really understand if there is a difference, which kind of difference between the role of ibrutinib inside the triangle versus the role of the two BTK of second generation inside the triangle. Thank you very much for your attention. And now we move to the second speaker of this symposium. It's my honor and pleasure to introduce my friend and colleague, Professor Carlo Visco from the Department of Hematology in the University of Verona, very close to Milan, with the title of Upgrading Combination in Newly Diagnosed Mantle Cell Lymphoma, Developments in Non-Transplant Setting. Thank you.
Thank you very much, Professor Zenzani. Good morning, everybody. Before starting, I wish to thank the organizers and PeerView organization, which was very nice to make this meeting possible. So my topic is going to be the non-transplant setting. So patients that will not be are not eligible to stem cell transplant, although what we have heard from Pierluigi, we will need to start thinking that this patient will disappear with the transplant disappearance. So we'll need to call this patient somewhat differently in the future. So let's dive initially into one case. This case is of Talia, a 70-year-old woman with stage 4 classical mantle cell lymphoma, who is, of course, unable to pursue autologous stem cell transplant. So she presented with quite important B symptoms, so weight loss, fatigue, fever, abdominal pain, which is quite typical of elderly patients with mantle cell presentation. The performance status, though, was 1. MIPI was high. The Ki67 was 35%, and we had no clue on p53 mutation or not. So the question is, what is the best choice for this patient? Is it less aggressive chemoimmunotherapy, as we were used to do, alone, or add a BTKi to induction therapy? And in this scenario, could a BTKi plus chemoimmunotherapy regimen be considered? So this is the main question, of course. And we will talk a little bit in detail about these regimens we will now have in clinical practice. And first of all, we will analyze the data about the SHINE, which may support the use of ibrutinib plus BR. Then we will deal with ECHO, which will support the use of acalabrutinib plus BR, and then followed by maintenance, doublet maintenance in this setting. And if so if we are supporting the BTKi combination, what are the dosing and safety management recommendations? And I think last but not least, what is the optimal duration of the therapy with the Acala combination? Is it continuous treatment through and after the rituximab maintenance period, so 2 years or more than that? So these are the questions we will try to answer together today. So how about the SHINE? You all heard about the SHINE. It has been published in the New England Journal of Medicine a couple of years ago. It has been a huge randomized phase 3 study, including 523 patients with elderly mantle cell lymphoma, more than 65 years of age, which were randomized between ibrutinib plus BR plus IR or maintenance versus placebo plus BR. The primary endpoint of the study was progression-free survival, and you're all aware that the study was positive in terms of primary endpoint, and the PFS curves you see were clearly in advantage of the addition of ibrutinib to the BR plus R platform. However, during the study, there has been quite an excess of toxicity, specifically infectious toxicity linked to the use of ibrutinib together with BR, and linked to the use of ibrutinib with rituximab maintenance in the following months after induction. And this made it clear that there was no advantage, no sign of advantage in terms of overall survival between the two arms. So what we gained from this study was that there is an activity of the drug, but when you use ibrutinib as BTKi, you may encounter an excess of toxicity. So how about the ECO? The phase 3 ECO trial tested acalabrutinib plus BR, of course, in patients aged 65 or more with mantle cell lymphoma that were obviously treatment naive. There was a stratification in terms of randomization, which was 1-to-1, and the standard arm was BR. In the upper part of the slide was BR for 6 cycles, given for 6 cycles, then followed by maintenance for 2 years with rituximab every 8 weeks, and then followed by the use of nothing else, because the other arm was Acala. You see, 100 milligrams bis per day, together with BR in the induction and together with rituximab maintenance after the end of the induction, and either acalabrutinib or placebo were continued until PD or toxicity. So there was no definite use of these drugs. The primary endpoint, again, similar to the SHINE, was progression-free survival. So these are the baseline demographics of the study. These are very in line with what we have seen with the SHINE trial. So the median age of this patient was exactly the same as for the SHINE, so 71 years old of age with 65 to 85 range. You can see that there were a bunch of patients, like 12 to 13% of blastoid variants. The MIPI score was high in 24%, and p53 mutation was not searched in any patient. This was a problem of this study. So the mutation was found in 7.4% of acalabrutinib treated patients, and with 22 patients, and was tested in 120 patients, so in a minority of them. Ki67 was tested centrally instead, and was elevated, so more, as definition, by definition, more than 30% or more in 46 to 49 of patients. These are the curves. On the left side, you see the full analysis population in terms of PFS, which again was the primary endpoint of the study. And if you look at the right side of the slide, you see how the curves do separate more clearly when deaths for COVID-19 were censored. Of course, if you remember, this trial enrolled most of the patients, if not entirely the patients, were enrolled during the COVID pandemic, which made it difficult to interpret the data, especially for patients that achieved a complete response for mantle cell lymphoma, but died for COVID complications. So, and if you look at the shape of the curves, I think it's of interest that the curves do separate both after the initial 6 months. So the difference given by the BTKi addition seems to be more important after the end of induction and not from the initial part of the protocol. So how about overall survival, which is probably the most important curve I will show in terms of in favor of the use of ECO in our clinical practice. And you see when, again, with the full analysis population and the COVID-19 deaths when they were censored, on the right side, you see that there is a trend. I would say it's a strong trend. It's P 0.07 in favor of Acala plus BR in terms of overall survival. And when you look at this curve, you have to keep in mind that there was a crossover in the study. So patients that did not have Acala at initial induction could cross over to Acala inside the protocol. So most of the patients that were treated with BR plus placebo in induction, when they relapsed, they had the opportunity to have acalabrutinib. This needs to be kept in mind when we deal with overall survival, of course, that encompasses the treatments that we receive also in second or further line of therapy. So what is new, what has been presented in a new fashion about the ECO? Of course, any one of us was trying to question how was the behavior of high-risk patients with addition of acalabrutinib plus BR. Because we are all aware that high-risk patients do not do well with BR plus R. That platform is not sufficient for patients with high-risk disease. And so how about when we add acala to BR and maintenance with rituximab plus acala in indefinite treatment? And it has been clearly shown at ASH last year in San Diego that all the patients either with blastoid variant or pleomorphic or p53 mutation and or Ki67 of 30% or more did benefit of the addition of acalabrutinib. And let me say, this is fair enough to say that when we looked at the data in the SHINE trial, we did not observe an advantage in the bunch of patients with high-risk disease. And the curves were not superimposable, but they were definitely not statistically significantly different. So finally, we can say from the ECHO, probably for the first time in first line, upfront mantle cell lymphoma, that we can show an advantage, a significant advantage in adding acalabrutinib also in the population of high-risk patients. And I invite you to follow this oral presentation that will be held on Saturday at 5 p.m. By Professor Matthew Dreiling about the analysis of high-risk patients within the ECHO trial. You see that this PFS curve shows that, again, the benefit of adding acala in this particular subgroup of high-risk patients is maintained over time, and it's highly significant also in this difficult-to-treat population. So how about MRD? MRD was tested with standard criteria along the ECHO trial. If you look at the histogram on the left side, both on the ABR arm and the placebo plus BR arm, you see that the achievement of a negative MRD is quite similar between the two arms. Even though in terms of complete remission, PET-driven complete remission, we have a 15 to 20% advantage in using acala BR in the induction, in the initial 6 months of induction. But what you can see from MRD evaluation, you see that maintaining the spread of MRD a long time when you use the doublet in terms of maintenance can ensure an MRD negativity that is higher than when you use just the rituximab arm in the placebo group. So MRD evaluation is in line with what we see in terms of results of PFS. So let's go to the second part and analyze the BTKi safety experience. You're all aware that we need to consider that any BTKi you will use in your clinical practice, I would say also at some point with the non-covalent BTKis, you will have to deal with some issues. And the first one is not to give concomitantly warfarin. This is known. Of course, you have to deal with atrial fibrillation using non-warfarin anticoagulation, of course. Hypertension can be managed with antihypertensives. You have always to monitor patients for signs of bleeding and monitor infections and secondary malignancies. And this is true for any of the BTKis you're going to use. Then there are some specific toxicity that can be addressed from acalabrutinib, where you have, of course, this headache that has been described since the initial studies that you can manage easily with the acetaminophen plus caffeine. And how about zanubrutinib? Zanubrutinib also has its own problems, which is related mostly by the higher relative occurrence of neutropenia that you can manage, of course, with growth factors. Having said that, if you go to the SHINE trial and we look at the toxicity in terms of interruption of treatment, you see that the incidence of grade 3-4 adverse events was 81.5% in the ibrutinib group and 77.3% in the placebo group, so not that different. But if we look at discontinuations, there was an excess of discontinuation in the ibrutinib group, and this was mostly due to the adverse events. And if you look at the deaths due to treatment emergent adverse event, this is where we had the problem in the SHINE trial. There was an excess of deaths in the ibrutinib arm basically due to toxicity of the combination in the induction. And shifting to the ECHO, So adding acalabrutinib instead of ibrutinib to BR, the toxicity was clearly more manageable, with similar rates of grade 3-4 events in the two arms, you see. And if you look at the overall discontinuation rates, they are roughly 20% less than what we observed with ibrutinib plus BR. So it's clear from this data that the combination is more, it's much more well tolerated. So if we look at events of clinical interest, I just separated them from all the others, because these are the events that really care in the clinical practice, specifically atrial fibrillation or flutter. You see the difference was not that high, or they were very similar among the arms in the ECHO study. The ventricular tachyarrhythmias were same in the both arms. If you look at bleeding, there was a little excess of general bleeding in the Acala arm, as expected. Hypertension was not a problem, was not an issue in the Acala arm. Infections were present, but again, not a major issue, as we had seen in the SHINE trial. Also, you see when we separate pneumonitis from general infections. And again, in terms of second primary malignancies, we did not observe in the long-term follow-up a difference between the two arms. So let's go back to our case, Talia. So BTKi plus chemoimmunotherapy regimen should be considered in patients aged more than 65 years, and when the triangle regimen is not feasible, of course. Dosing and safety management recommendations should be considered through the treatment journey. I also suggest out of the paper about what we might do in the future, so would be to reduce probably bendamustine dose when we deal with some toxicity related to the drug. And how about continuing acalabrutinib during or after the rituximab maintenance period? Of course, these are open questions, and we can discuss them further during this meeting. So the conclusions are listed here. We've seen how the addition of acalabrutinib to BR in older patients with mantle cell lymphoma with a median age of 71 years old reduced the risk of disease progression or death by 27%, with a 36% risk reduction when censoring COVID deaths, as we have explained and shown before in the slides. The safety profile of acalabrutinib plus BR was consistent with that of the individual drugs, as you've seen from main toxicity that we've listed on the table we've shown before. The PFS advantage, and you can recall the shape of those curves, is maintained over time in all risk populations, but specifically, and you will hear from the presentation at HIA next Saturday, even in high-risk populations. So the ECHO clearly suggests a possible positive trend for overall survival in favor of ABR, but of course, longer follow-up is needed to see whether those curves will become straightforward and significant different along time. So I'm done, and I thank you very much for your attention.
Last but not the least, I invite on the podium Dr. Christine Ryan from Dana-Farber Cancer Institute in Boston, with the title of Upgrading of Chemo-Free Option and Implication for Sequential Care. Christine.
Good morning, everyone. Thank you, Professor Zanzani, and thank you also to the organizers of this session and PeerView for the opportunity to share with you all today on this topic of upgrading to chemo-free options and implications for sequential care. So we will also start with a clinical case for this session. And in this situation, we have David, who is a 78-year-old gentleman with stage 4 mantle cell lymphoma, unable to pursue an autologous transplant. He similarly has presented with fatigue, upper abdominal discomfort, was found to actually have a gastric mass, and has widespread lymphadenopathy, and his past medical history is notable for hypertension. Additional findings are that his Ki67 is 25%. He does not have a TP53 mutation, but his performance status is only 2. So with the data that we'll review, we will be seeking to address the following questions. What is the rationale for considering a chemo-sparing regimen with a BTK inhibitor here? Or would a BTK inhibitor plus a lower intensity chemoimmunotherapy regimen be more appropriate? And what are the dosing and safety considerations with chemo-free BTK inhibitor options? Also relevant to this portion of our session today is what if we have the exact same patient, but with a TP53 mutation? And how might that change our management of this patient? And so we'll look at data that will help answer the question about whether a chemo-free triplet could be an option in this setting of higher risk disease. Now, chemo-free doublet and triplet regimens with the BTK inhibitor are in rapid development for frontline mantle cell lymphoma. This table, I think, clearly gives you that overview that there are a number of different studies investigating doublet and triplet regimens. In terms of doublet regimens, we have studies that have reported on outcomes of both ibrutinib and acalabrutinib with rituximab. There's an ongoing study with zanubrutinib, and then we also have doublet data of a BTK inhibitor plus BCL2 inhibitor combination from the Simpatico study, which looked at ibrutinib plus venetoclax. There are also a number of triplet combination studies looking at combination of both BTK inhibitor, BCL2 inhibitor, and anti-CD20 antibody. There's also a study looking at the combination of acalabrutinib, lenalidomide, and CD20 antibody. And so in our upcoming minutes, we'll focus on a few key studies here, recognizing that we cannot cover all the data in this table, but really want to emphasize that this is a rapidly evolving and developing area in the treatment of frontline mantle cell lymphoma. So starting with the doublet data, let's first focus in on the phase 3 trial, the ENRICH study, which was presented just at ASH this past year. And this was a randomized phase 3 study looking at standard of care rituximab-based chemoimmunotherapy compared to ibrutinib plus rituximab in elderly patients with mantle cell lymphoma. You can see the eligibility listed here. Patients were required to be over the age of 60 years, newly diagnosed, and considered unsuitable for autologous transplant. The standard of care arm was rituximab chemoimmunotherapy. Investigators chose up front whether this was R-CHOP or bendamustine rituximab. And in the experimental arm, patients received ibrutinib plus rituximab. You can see that all patients received rituximab maintenance, and those patients in the ibrutinib-containing arm continued ibrutinib until disease progression or unacceptable toxicity. Here is the progression-free survival curve from the results of this ENRICH study. This was a positive study. It did meet its primary endpoint, which was progression-free survival. And when we see the data across the entire study, you can see that the combination of ibrutinib plus rituximab did lead to a significantly increased progression-free survival compared to standard of care chemoimmunotherapy. And you can see that the median PFS in the experimental arm compared to the standard of care arm was improved by nearly 24 months or 2 years. Importantly for this study, though, I do think we need to look at the subgroup analysis, which of the standard of care chemoimmunotherapy arms, either looking at those patients who received R-CHOP or BR. And here we see that the majority of that progression-free survival benefit in the overall study was really driven by the R-CHOP comparison arm. You can see the wide separation, the progression-free survival curves, which is in contrast to the comparison curves for ibrutinib rituximab compared to bendamustine rituximab, where we see nearly identical results with the 5-year progression-free survival. Now, we also have doublet data for the combination of acalabrutinib plus rituximab. There's a US study conducted at MD Anderson investigating this combination, and then more recently presented at ASH this past year was the phase 2 Altamira study conducted by the Nordic group. This study enrolled patients over the age of 60 years, similarly ineligible for autologous transplant. And an important component of this study was that it actually used MRD-guided treatment for a time-limited acalabrutinib rituximab treatment. You can see very promising early progression-free survival results here with a 2-year PFS of 75%. And you can also see this curve here was an additional analysis that the investigators completed looking at a pooled cohort of patients who had received standard of care therapy, and we see favorable results of the acalabrutinib rituximab combination when compared to standard of care chemoimmunotherapy. Now moving on to our triplet regimens. So here we'll focus on data for BTK inhibitor, BCL2 inhibitor, and anti-CD20 combinations. And the first such triplet that was investigated and reported comes from the OASIS-1 study. And this study investigated the combination of ibrutinib, obinutuzumab, and venetoclax. Initial results showed that this combination was well tolerated and had very promising results in specifically high-risk patients. You can see over a quarter of the patients in the treatment-naive cohort had a high-risk MIPI score. There was a percentage with p53 mutation, and 40% actually had deletion 17p. So overall, enriched for patients with p53 aberrant disease. Now, at ASH this past year, we did see updated results from OASIS-1 as well as OASIS-2, which I'll show you on the next slide. And these results show that there was sustained disease control both in patients in the relapse refractory cohort as well as those patients with previously untreated disease. And you can see in this curve here that now with a 4-year progression-free survival of a very encouraging 80% in the treatment-naive population. Now, the OASIS-2 study, as I alluded to, is a phase 2 randomized study that randomizes patients either to the combination of ibrutinib with CD20 antibody or the triplet of ibrutinib, CD20, and venetoclax. What you can see in these results is that both the doublet and the triplet, but of course more so the triplet, does induce very high rates of MRD negativity. 80% of patients in the triplet arm had MRD negativity at the end of induction. And what we do see is that, as perhaps not unexpected, when we add another agent, we do see increased toxicity. But overall, those adverse events reported even with the triplet arm were manageable. Now, in terms of additional triplet data, we have studies with both acalabrutinib and zanubrutinib as well. We at Dana-Farber are leading a study looking at the AVO triplet of acalabrutinib, venetoclax, and obinutuzumab. You can see that these 3 agents are introduced in a stepwise pattern. And thus far, we have seen very encouraging response rates with this triplet regimen, both in patients with relapse refractory disease and in our treatment-naive cohort. In this study, specifically, there is a cohort of patients with TP53 aberrant disease, and in particular, the triplet regimen seems to be effective even in these high-risk disease patients. And that brings me to the bovine study, which is the first published study of a triplet regimen in specifically a cohort of patients all with p53 aberrant disease. The study was led at Memorial Sloan Kettering Cancer Center and investigated the combination of zanubrutinib, obinutuzumab, and venetoclax in 25 patients with previously untreated mantle cell lymphoma. You can see here that the study similarly introduced zanubrutinib and obinutuzumab before introducing the venetoclax, thereby lowering the risk of tumor lysis syndrome as patients have some upfront debulking prior to initiation of the BCL2 inhibitor. The results of this study, with a median follow-up of just over 2 years, we see very high overall response rates and complete response rates. So a complete response rate of 88% in this population of patients, all with p53 aberrant disease, and very encouraging progression-free survival, a 2-year progression-free survival of 72%, which to date is the most favorable results we've seen in a cohort of patients with this TP53 aberrancy. Now, to just tell you what's on the horizon in terms of these, quote, chemo-free doublet strategies, there are 2 ongoing studies that will provide important data in this regard. The first is the Mangrove study, which is an ongoing randomized phase 3 trial comparing zanubrutinib rituximab versus bendamustine rituximab. So it's similar to the ENRICH study, which we already saw the results of, but in this case including the 2nd generation BTK inhibitor zanubrutinib. This study, which is actively enrolling, enrolls patients who are over the age of 70 or between age 60 and 70, but with comorbidities that preclude autologous stem cell transplant. And then I will also draw your attention to the ongoing acalabrutinib rituximab study in the UK, the Caramel UK study, which is looking at this doublet combination for elderly or frail patients with newly diagnosed mantle cell lymphoma. So while the focus of today's session is frontline management of mantle cell lymphoma, an important consideration is, as we move these BTK inhibitors increasingly into the front line, what is the optimal treatment for our patients as they, unfortunately, inevitably seem to progress and will require second and third line therapy? So coming back to our case, we have David again, our 78-year-old gentleman with stage 4 mantle cell lymphoma, unable to pursue an autologous transplant, who does have a p53 mutation. And let's say you had treated him with, for example, based on results of ENRICH and ibrutinib plus rituximab combination, but he develops disease progression. And so what happens next? Do we move to a non-covalent BTK inhibitor or consider CAR T-cell therapy? And how do his high-risk factors and overall fitness inform this choice? And is there potentially a role for a bispecific antibody for him down the road? And so we'll briefly touch on some data in this regard. So the Bruin study, as you may be familiar with, is a large study investigating the non-covalent BTK inhibitor pirtobrutinib. And to remind you of the data specifically in relapse refractory mantle cell lymphoma, you can see that in patients who had received a covalent BTK inhibitor and then were treated with a pirtobrutinib, the overall response rate was under 50%. The complete response and partial response rates shown there at 16% and 34%. And the median duration of response was 22 months for those patients who did respond. However, when we look at the progression-free survival curves, we do see that the median progression-free survival in patients who had previously received a covalent BTK inhibitor was quite short at just under 6 months. I think highlighting that pirtobrutinib can be effective and potentially as a bridge to another therapy, but we're seeing that for patients who do not respond, unfortunately, do not have a very favorable progression-free survival with this agent alone. Just to highlight, there is an ongoing phase 3 study, however, of pirtobrutinib, the MCL 321 trial versus covalent BTK inhibitor. So in this study, patients with at least one prior line of systemic therapy are enrolled and randomized to either pirtobrutinib, or investigator's choice BTK inhibitor, either ibrutinib, acalabrutinib, or zanubrutinib. And so this will provide very important data head-to-head of a non-covalent BTK inhibitor versus covalent BTK inhibitor. Now, what about CAR T-cell therapy in this setting? I'll briefly highlight results from the ZUMA-2 and the TRANSCEND study. The ZUMA-2, we have now 3-year results which show efficacy of anti-CD19 CAR T-cell therapy in this setting, along with extended follow-up data for progression-free survival. You can see now with a median follow-up of 3 years, high overall response rate of 91% and complete response rate of 68%. And what we can see in these progression-free survival curves are that patients who achieve a CR, or complete response, do have favorable overall progression-free survival as well as overall survival. And you can see in the 2-year PFS rates listed here that those patients with a complete response do have a 2-year PFS of 72%. We see, however, that patients with only a partial response following CAR T-cell therapy do have inferior outcomes. And so highlighting the need that we continue to need development of new treatments post-covalent BTK inhibitor. This is the data from the TRANSCEND study looking at liso-cel in patients with relapsed or refractory mantle cell. You can see that the overall response rate was 83% with a complete response rate of 72%. Median duration of response was 15 months and the median progression-free survival was 15 months as well. And now with a median follow-up of just over 2 years, we see that the overall survival curves here with a median overall survival of 18.2 months. And so as we think about where the field is headed in terms of new therapeutic modalities and options, particularly in the relapse refractory setting, I wanted to highlight the GLOBRIGHT trial, which is a phase 3 trial evaluating glofitamab monotherapy in patients with relapse or refractory mantle cell lymphoma. This study will randomize patients 1-to-1 either to receive glofitamab, bispecific antibody, or to standard of care either with bendamustine rituximab or R-squared. And this will be a very important study in potentially establishing the role and leading to regulatory approvals potentially for glofitamab in relapse refractory mantle cell lymphoma. So in conclusion, we've reviewed data for BTK inhibitor and rituximab doublets. Specifically, the randomized ENRICH study demonstrated that the combination of ibrutinib and rituximab versus chemoimmunotherapy did indeed meet its primary endpoint, but that progression-free survival benefit was mainly driven by the RCHOP arm. We also reviewed data, specifically from the Altamira study, that showed that acalabrutinib and rituximab demonstrates promising efficacy in the frontline setting. And an important ongoing phase 3 study is the Mangrove study, which is investigating the combination of zanubrutinib and rituximab compared with BR. Now, there are also a lot of promising results thus far from triplet combinations, and we are seeing, particularly for TP53 aberrant disease, that a triplet combination approach can be an effective treatment regimen. But as of right now, longer follow-up, larger studies, and ideally randomized studies will be needed to establish these as a universal new standard of care. And our current treatment options following a covalent BTK inhibitor include anti-CD19 CAR T-cell therapy and pirtobrutinib. There have been promising results for the bispecific antibody glofitamab with an ongoing phase 3 study, but this does remain an area of unmet need, particularly as we see increased use of BTK inhibitors in the front line. All right, with that, I will thank you for your attention, and we will now move into the question and answer section of this session.
So now we can start with these Q&A questions with the by the system, also with the old-fashioned way. There are the microphone, several microphones in the room, as you want. No people on the microphone so far. We can start with some questions by the system. So I have a question for you, Carlo. Do you have any sense from ECO about which patients may benefit most from ongoing BTK maintenance treatment?
Well, so the question is whether there's any data in terms of the usefulness of maintaining the BTKi treatment a long time after the initial 24 months of rituximab maintenance. And of course, this is an answered question for some reasons. The first reason is that we don't have such a prolonged follow-up to see what happened to patients that interrupted the drug. The second issue is that all the data we have so far, at least in the elderly, do indicate that the standard of care would be to maintain the patient with the BTKi. But of course, the triangle data also show that interrupting the treatment with BTKi after 2 years does not affect the prolonged progression-free survival. So it's an open question. I think it's open to considerations. I'm personally open to a fixed duration maintenance.
Okay, thank you very much, Carlo. Question for Christine. High Ki67 percentage, P53 mutation, blastoid histology are some of the well-known high-risk factor in mantle cell, but are these any in particular that you think makes it more likely a patient could benefit for very aggressive therapy up to and including early CAR T?
Sorry, what was can you repeat the second half of the question?
I mean, do you think it's more likely a patient could benefit, this kind of patient, from very aggressive treatment up to including also an early CAR T-cell treatment?
What were the CAR T-cells?
For really aggressive, like Ki67, more than 50% and so on.
Yes, so I think, yes, those are all features that we see of high-risk aggressive disease. I think those are patients that we absolutely do, in my practice, favor more aggressive treatment for. I think that there are there could be a role for early escalation. For example, if these patients are not responding well to chemoimmunotherapy, now with the addition of BTK inhibitor, it will be interesting to see if that can help with, in particular, with some of these high-risk patients. As Professor Visco mentioned, we are looking forward to that updated abstract presentation on Saturday of the high-risk groups of the ECHO trial. And there are studies that are currently ongoing investigating the use of early escalation, so patients who perhaps do not respond as we would hope to initial therapy and then moving along to CAR T-cell therapy earlier on. I think those studies will be important to establishing whether there is a role for example, CAR T-cell therapy or even down the road bispecific antibody therapy, moving it into earlier lines of therapy for these patients with high-risk disease features.
Yeah, because one of the most important points for the next situation, according to the registration of triangle in front line for a young patient, is that if there is a refractory patient to triangle study or an early relapse, which is the best second-line treatment for these patients? Because actually, in this setting, we can use pirto as a second line, as a single agent, pirto as a treatment, also like a bridge treatment to CAR T, because as you know, CAR T we can use only in third line. This is a very important point for the future concerning this kind of lack of second-line treatment outside pirto in this setting of patients. What do you think, Carlo, and then Christine, about that?
Well, it's a good question. It's an open issue again. Of course, we're lucky that patients that do progress during the triangle are very few. But those few patients need to be managed depending on the country you are in, because you know that pirto is available in Europe in any BTKi treated patients, any line, but this is not the case in the US. So you wouldn't be able to use a pirto as in second line in the US because it says more than 2 lines prior therapies. So what I would do, it would be to manage the patient as far as possible to lymphocytoapheresis, and then between the apheresis and the CAR T cells, which is of course the option I would choose with pirto again. I would also consider some bridging therapy, which can be based on low-dose bendamustine or association with bendamustine after lymphocytoapheresis.
This is the status from Europe, but for the United States, Christine?
Yeah, so I think that as Professor Visco said, thankfully we are not seeing patients who progress on a BTK inhibitor. I think that what remains to be seen about with these triangle patients is how long that they have been on maintenance therapy prior to progression, and that definitely affects how we think about the risk and their subsequent lines of therapy. I think in our situation, we are often able to use venetoclax, even though it is not technically FDA approved for mantle cell lymphoma, we do have access to that for our mantle cell lymphoma patients. That can often be used or added to BTK inhibitor. And as Professor Visco was saying, the goal is basically to get the patient to apheresis for their CAR T-cell therapy. And then beyond that, we can use the pirtobrutinib as bridging as well.
Thank you very much. There is a question again for you, Christine. Is there data on p53 mutation patients in the ENRICH trial?
That's a wonderful question. I don't recall that subgroup analysis was presented in detail at the ASH presentation. I'm sure that the study is analyzing that, though, and hopefully when we see in the full publication, that data will be more readily available.
A direct question to Carlo. Why do you think SHINE showed higher incidence of infection in comparison to ECO study, despite using BTK inhibitor only for 6 months in any role for anthracycline and alkylating agent during infection?
Yeah. I think they shifted the question. However, if I understood well, the question is about infection. So there's a misunderstanding because in the SHINE trial, it's not only 6 months IBRU. The IBRU is continued until progression, same as for ECHO. And if you ask me why infections are more frequent in the combination with ibrutinib, I answer with the tables we've seen in the previous presentation, showing that there is a major toxicity in terms of lymphocytopenias and in terms of cytopenias in general, also neutrophils. The impact of ibrutinib is quite a little higher than with Acala. So this is one of the reasons why probably we observed an excess of toxicity, infectious toxicity in the ibrutinib instead of the Acala. But of course, there's a lot of data down there in the preclinical data showing the impact of these different BTKis on the activity of neutrophils and lymphocytes and on immunoglobulin levels a long time. So these are all the factors that intervene in differentiating the figures we have with the two different treatments.
Okay, now there is a question for all the faculty. Autostem cell transplantation in B53 mutation, Ki67 high percentage, plastic variant mantle cell after triangle. For all patients, some of them selected patients. Christine, if you can start.
Sure. I think, Professor Zanni, as you said in your talk, it really is an individualized patient choice. I think that, what we saw from the triangle data, that updated subgroup analysis, that when we look specifically at the P53 aberrant patients, perhaps there was still a benefit of transplant, the high Ki67, a benefit in that group. I think what we know from the US ECOG-ACRIN study is that those patients who achieve an MRD negative complete response do not benefit from autologous transplant. So I think potentially what we're seeing is more a reflection of, does the induction therapy, can it effectively induce that deep remission for patients? And if not, what remains to be seen is transplant that next best step, or is it some other escalation or some other type of therapy, as we were discussing earlier, early escalation of CAR T-cell therapy. So I think for those patients, ideally we would be enrolling them on a clinical trial that's investigating a regimen that can hopefully advance the field specifically for those high-risk patients, in part because of the publication of the Bovin study in the United States. With the inclusion of that regimen in our NCCN guidelines, many have adopted that as a standard for those specifically P53 aberrant patients. And so I think it really depends, again, as we've said, on the country that you're practicing in. I think that in general, we do not, we try to move away from chemotherapy for those higher-risk patients into our more targeted therapies.
This is a demonstration that the American colleagues are very lucky, because you can use, according to the NCC, again, right now, the Bowen study in the high-risk patient in frontline treatment. What do you think about this question, Carlo?
Well, I totally agree with Christine. We now, in this specific time being, we're focusing on the triangle curves. We're showing that there's still some room for transplant somehow in this high-risk population, but I think the next step in mind we need to perform, is to consider that these patients, that mostly of these patients that progress during or are high risk, some of them are ultra high risk patients, so we need to find solutions that go outside immunochemotherapy up front. And so this is the direction we will have to take. Having said that, I agree that there's still some room for transplant in some patients. It's not what I like to do in my clinical practice, but curves show that there might be an advantage in keeping the transplant active in those particular population. Yeah.
So the answer is inside your vote. You said 78% for a triplet treatment. I think it could be the future for this high-risk patient to use a triplet treatment, because the preliminary data from the Bowen study, but also for the other two preliminary data, are very interesting in terms of the rate of complete metabolic response, the high rate of MRD negativization. This could be the best treatment. So far, of course, American colleagues are very lucky, as I said before. For Europe, we can decide patient by patient if to include in frontline in combination with ibrutinib also autostem cell transplantation. And after this, I want to conclude with 2 slides concerning the summing up of this symposium. So we are facing a real Copernican revolution in the world of mantle cell lymphoma patients. The triangle and the ECO study will completely change frontline treatment with the introduction of BTK inhibitor and the definite deletion, the definitive, of the outer stem cell transplantation according to this last discussion. The advent of second-generation covalent BTK and the introduction of the first non-covalent BTK inhibitor peer-to-boot is another important point for the second-line and third-line treatment for our patient. Also, the potential of triplets, OSIS, LR, AVO, Bowen, window of 2, for high-risk patients with the mutated p53 and also the high percentage of Ki67, and also the variant, histology variant. The final data from ENRICH study presented at the last ASH meeting is the update of the simpatico study presented a few days ago by Michael Wang at the last ASCO meeting. And the forthcoming arrival of definitive data from the Mangrove concerning the role of in frontline of Zanu plus rituximab in patient ineligible for auto stem cell transplant. The Traverse trial, both of them are in frontline concerning the role of acalabrutinib in combination plus also the consolidation maintains treatment with acalabrutinib. And finally, the BRINE study, the BRINE 321, in second line comparing Pirto versus all the 3 BTK covalent inhibitor. And the second product of CAR-T, liso-cel, that is with the same level of efficacy, but is with a very good safety profile when you compare with the other product that normally we are using right now. And the interesting preliminary data concerning the role of bispecific CD20, CD3 glofitamab with the addition of an ongoing phase 3 GloBrite study. So all these data point to and will inform a new therapeutic algorithm and continuous and dynamic evolution which will significantly raise the bar of the therapeutic success for our patients with mantle cell lymphoma. And of course, we can visit at peer reviewer, complete and submit your post-test evaluation for credit, download the slide and practice aids. And thank you very much for your attention. Have a good meeting.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/TZE860.